you so much. And it's my pleasure to introduce to you Dr. Kidist Yimam. She got her medical training at University of Nevada School of Medicine, and then she proceeded with California Pacific Medical Center with internal medicine, GI fellowship, and now she's transplant hepatologist there. I have a little story to share with you with Dr. Kidist Yimam. It was at the end of the day. A few years ago, a pharmaceutical rep came to the office and crying. He said, "My mom is dying, and I know you're the only one who can help me." I said, "How can I help you?" He said, she's in that particular hospital, and her hepatologist is Dr. Kidist Yimam. And I said, I never heard about this name before. So I called Tim Davern from CPMC and I said, Tim, do you have the hepatologist like that? He said, yes. So he connected me with Dr. Kidist Yimam, and she saved her life. So thank you so much for doing that.
Thank you. Thanks for the warm introduction and for having me participate in this program today. So my portion of the talk is giving highlights on hepatology from ASLD programs that were presented at DDW. Please note that the EASL program just ended yesterday, and so I'm sure those, I'm not including anything here today because of the time limit, but I'm sure those will be covered in your upcoming liver conference. I have nothing to disclose, so I thought that I would go over a few pertinent topics that are currently timely. That would include COVID-19 and the escalating rates of alcoholic liver disease that we all have been seeing, an abstract covering NASH and HCC risk, an update on cholestatic liver disease, particularly PBC, and use of Ocaliva in PBC, and an abstract highlighting healthcare disparities in liver disease, particularly HCC. So the first abstract that I'd like to go over is looking at trends in alcohol-related liver diseases during the pandemic. This was data from the script group that was presented. And Dr. Catherine Fernette was kind enough to let me use some of her slides. So this was a retrospective analysis looking at hospital admission trend at Script Medical Center, and they looked at alcohol-related diagnoses, particularly patients admitted with acute alcoholic hepatitis as well as pancreatitis. Looking at ICD codes, they compared the rates from prior to the pandemic and after the pandemic till December 2020. They also looked at public trends from the San Diego County on a number of patients that were affected by COVID and relative to their own in-house case. Also looked at data on alcohol use and amount of money people have been spending during the pandemic and compared the trend. So this is looking at rates of COVID in San Diego, which parallels their data from Script. Significant number of patients affected, as you can see, up to 50, 60,000 in the month of December. So, significant number of patients were definitely affected by COVID, as we all know. So another data that they highlighted as a reference is data published from a journal of psychiatric research that actually looked at patients with alcoholic use disorders that were seeking help. Their audit score, which is alcohol use disorder identification test score, certainly was a lot higher, trying to point here, certainly a lot higher, as you can see here, compared to, this is during the lockdown and this is during the open phase. And when they looked at patients that had harmful use or probable dependence or significant dependence, as you can see in the red compared to the blue, there were many more patients that were definitely affected by the degree of the alcohol they were using. This is paralleling with the amount of money spent on alcohol during the pandemic, which is impressive, about 16 billion in the month of December. So they showed that, it's a busy slide, but the bottom line is during the pandemic, they had about 32% increased rate of people presenting with alcohol-related disease. They had about 36% increased in alcohol-related pancreatitis. Non-alcohol-related liver diseases, rate of admission, as you can imagine, initially was lower because we were seeing less patients in clinic, but that came up to the prior to pandemic level. There was another abstract presented at the clinical plenary session, which also really showed the same thing. We were seeing a lot more number of patients with alcoholic hepatitis and pancreatitis with many consequences. What they highlighted is that even after the opening time, they are still seeing a lot more patients with acute alcoholic hepatitis and complications of that. So I think we're going to be seeing a lot more people coming up with alcoholic-related liver disease as we move forward. So the pandemic was certainly associated with harmful use of alcohol. Certainly the social isolation is probably the factor. So we really need to be aware of this problem, definitely screening aggressively at-risk alcohol use disorder, which is escalating and will likely continue, and work definitely need to be done looking at what are the consequences of the pandemic, not just an alcoholic liver disease, it could be psychiatric, cardiovascular health, et cetera. So that was one interesting abstract that I thought I would go over. The second article or abstract looked at, this is just an interesting finding of the use of statins in preventing liver cancer in patients with NASH cirrhosis is such an impressive result that I thought I would highlight that. So this was a retrospective study looking at NASH-related cirrhosis patients between the year 2009 and 2016. These patients were followed till they got diagnosed with liver cancer or needed transplant. Liver cancer diagnosis was confirmed by biopsy or more frequently with imaging confirmed criteria of HCC. So they looked at multivariable analysis looking at factors associated with HCC development. And they also looked at if the amount of they defined statin use as having a daily cumulative dose of at least 28 days to be included in this study. So the results showed that they overall had about 950 patients with NASH-related cirrhosis. Of those, 53% had biopsy-confirmed NASH cirrhosis and 46% had clinical diagnosis of NASH cirrhosis. 82% of those patients developed HCC. Mean follow-up time was 4.6 years plus or minus 3. And after adjusting for multiple variables, male gender, older age, and worst liver disease status by low albumin level were associated with HCC development, but more impressively, statin use was associated with a lower risk of HCC at a hazard ratio of 0.49. They looked at hydrophilic versus hydrophobic statins. So hydrophilic statins are Crestor and Provastatin, and the other ones are lipophilics. The lipophilic statins are the ones that showed benefit more so than the hydrostatins. That has something to do with membrane permeability and being retained in the liver cells. So this is a very impressive result, and each year use of statin added an additional 20% reduction in HCC. This is in NASH cirrhosis patients again. So statin use, again, significantly reducing NASH-related liver cancer and NASH cirrhosis. There is, I think, enough data emerging in a reduction of cancer and hepatitis B-related cirrhosis, hep C-related cirrhosis, and also prevention of hepatic decompensation in different patient cohort. Lipophilic statins being more beneficiary again. In liver clinics, et cetera, we tend to see patients that were referred to us for cirrhosis, but their statins are discontinued. So I think we need to think about this emerging data, and it is actually beneficiary to continue that. Though, again, we're not currently starting statins in patients with cirrhosis with no indication that may be emerging. There are a few randomized clinical trials currently going on, so look out for more data. Another abstract that was interesting to mention and timely because of the recent FDA report of the safety of Ocaliva or obeticholic acid, in patients with PBC. This is, again, the background of this is that, as you know, obeticholic acid was approved in 2016 for patients with PBC that have incomplete biochemical response to urso or are non-responders, but recently, FDA has reported severe adverse events in patients that have cirrhosis treated with obeticholic acid. That included 25 cases of liver failure. Of those 25, 18 had compensated cirrhosis. Of the 18, actually 10 of the 18 had evidence of portal hypertension. So the median time from prescribing or starting the medication to liver failure is interesting, is that in this 25 cases, it ranged from 2 weeks to 10 months. 4 needed transplant and 1 actually died of liver failure, unfortunately. But this these patients were reported through the adverse event reporting system of the FDA, but we don't really have any data comparing what are the outcomes of non-obeticholic acid treated matched PBC patients with those that are actually on obeticholic acid followed for outcomes. In this particular abstract, looked at that. So this was, again, comparing PBC patients with well-compensated cirrhosis matched with propensity-matched cohort of cirrhotic PBC patients without obeticholic acid. It was a retrospective study using data from the VA programs. Remember that VA patients are mostly males, not females, and so this is not our classic PBC patient population. But that being said, they looked at 509 patients with compensated cirrhosis. 21 were on obeticholic acid, matched with 84 non-obeticholic acid users. Initial doses of maintenance dose of obeticholic acid was 5 milligram in about 90% of the patients. Right, usually it's a 10 milligram maintenance dose, so this is a cirrhotic group, and they were using a lower dose. And of this, 23% of obeticholic acid users ended up having decompensated cirrhosis versus 26% of the non-users. But after matching for multiple variables, actually obeticholic acid had a 3.4 percent increase hazard ratio for leading into liver decompensation and those that were on treatment. But they did not find association with liver-related mortality or needing liver transplant. So there was an increased risk of progressing into hepatic decompensation with the group that was on treatment, which was a 3.3-fold. So the mechanism of the injury is not clear. I did reach out to Intercept, and I don't think they know yet. It could be because metabolites could be high, and there could be shunting in patients that have portal hypertension, but that is still yet to come. And again, VA patients, this study looked at VA patients and not our typical PBC patients, which are female, and more studies definitely is needed to see the comparative group and their outcomes in the future. So one thing I wanted to highlight here is that there was a recent label change I think we should be aware of. Like previously, after the initial approval of obeticholic acid in 2018, we had another updated label insert, and that was mainly looking at using a low dose obeticholic acid in those that have child B or child C cirrhosis. But the newer insert really highlights the fact that we need to avoid prescribing obeticholic acid in those that have decompensated cirrhosis or those with cirrhosis with evidence of portal hypertension or history of of portal hypertension. I'm going to mention one abstract which is important that looked at racial disparities of HCC care in the US, and this was a very large study from the UT Southwestern groups that looked at differences in overall survival in early tumor detection. So not to waste more time, so they looked at multiple databases, looked at outcomes of, again, HCC in terms of stage at diagnosis and their survival. They had overall 35 studies included, about 500,000 patients, 50% white, 17% Black, 18% Hispanic, and 5% Asian. And so Black patients with HCC actually had worst overall survival compared to white. Odds ratio here is over 1, insignificant. Hispanic patients with HCC had better survival than non-Hispanic white patients. Here is the significant hazard ratio down here. And Asian patients with HCC had better survival than white patients. So Asian and Hispanic had better survival compared to non-Hispanic white, versus Blacks actually had the worst survival. And Black patients are also less likely to be diagnosed at early stage compared to whites, and there was no difference in terms of detection or stage of the disease at diagnosis in Hispanic patients compared to whites, and also no difference in the stage Asian compared to white. What's impressive here is that when you control for where they got care, right? So patients that we're seeing at academic centers compared to population-based practices, there was no difference between outcomes of Black versus white. So I think the difference is in population-based. This is really highlighting, right, the access of care issue. So if they had access and they are at the right place, their survival was actually not different from white. So limitation is a retrospective study. They didn't account for stage of liver disease, which I think is important in looking at outcome. And few studies included, again, I just meant for liver disease and tumor stage or number of treatment given for HCC. So there are multiple confounders, but in conclusion, I think that's a very important difference that is highlighting, even though there's a lot of work, again, showing that there is this disparity. We currently don't have that many studies actually looking at, what kind of changes can we make that actually could make a difference. So I think that should be the next step for all of us. Thank you.
Great, thanks so much for our panel of speakers. Now we have some time for Q&A, so definitely if you have a question, please come up to the mic, or for our participants that are joining us virtually, I think you can, I don't see the Q&A screen, but I'm sure they will get it, so you can submit those. I'll go, oh, there's one right. Please, sir.
I have a patient with PBC cirrhosis and...
Can we get the mic, please? Can't hear.
Hello? Yes. Good morning.
Good morning.
I have a patient with PBC cirrhosis, and we tried prednisone, we tried Imuran, and then finally we put her on Ocaliva, and it did work very well. Now we have this criteria that if you have cirrhosis, should stop the Ocaliva. And we are obligated to do that, although she's been on Ocaliva for 2 years, and she's getting actually better. So we are in dilemma now. We have to stop it because of this recommendation. So any idea?
It sounded like that patient has PBC with autoimmune hepatitis overlap syndrome, right? If you're using immunosuppression with obeticholic acid, does she have any evidence of portal hypertension? Like, is she early stage cirrhosis or?
she doesn't have portal hypertension based on no big spleen and no varices.
I think if that is the case, that's the patient that you can safely monitor closely and continue Ocaliva, because the contraindication is those with decompensated cirrhosis and or have portal hypertension. As long as you're monitoring her closely, meaning like I personally would do labs every 3 months in frequent, clinic visits to monitor for progression of the disease. And I think you may be safe to continue to do so. But I think you're highlighting a very important point, is that there is a gap, right? What are we going to do with those patients that are a bit more advanced cirrhosis, but not child A, child B, that have enlarged spleen and evidence of portal hypertension, which you can see in PBC at an earlier stage, right? They would not qualify for Ocaliva now. They may be too advanced for clinical trial. So I think you're clearly are highlighting the gap that we need to figure out how to deal with. But for your own particular patient, I think you can monitor her and continue Ocaliva if no portal hypertension.
Okay, thank you.
Okay.
Great. We have one question from our virtual audience. This is for Dr. Lewin. With respect to low residue diet, I guess the question is, could you give us a better sense of what that specifically means and sort of how you approach that when discussing with patients?
So low residue diet is often recommended for patients who have either stricturing type of disease, or even in the setting of an acute flare of ulcerative colitis. And so that's something that's long recommended. And really what we often think about is really essentially a low fiber diet compared to what we would recommend for many of our other patients, which is really targeting 25 to 30 grams of dietary fiber per day. And the way I actually try to help patients conceptualize the idea of a low residue diet would be thinking about, if you kind of chewed things well, and could it really fit through a very small orifice, and if you had a stricture, and that kind of helps, could it fit on the head of a dime after it's been chewed well. And so I think that's something that I will often counsel patients with. But I think really the takeaway from the DINE-CD study is that even patients with active Crohn's disease, and they didn't risk stratify against stricturing versus fistulizing different subtypes, from that DINE-CD study is really that eating a higher fiber diet is really should not be discouraged for these patients. And so I think that was the main takeaway there.
Perfect. And this sort of a question / input from Dr. Park. We certainly are getting a lot of advertisement and marketing about EPI, and you showed that it's not as common as some of the other GI disorders that we approach. What are your thoughts on how we approach EPI? You mentioned about screening. But also about how we should approach the therapeutic cascade and how to treat these patients.
Sure. I think the general environment is one of, speaking to the last abstract, of under-recognition and under-treatment, and I think there's still a lot of need to disseminate and educate the primary care community and the GI community about EPI, its presence, and when to test and when to screen. Having said that, the spectrum of symptoms of EPI is quite nonspecific, short of clear steatorrhea, particularly if you're thinking about earlier EPI where you have very nonspecific symptoms like bloating, distension, increased flatulence. This could also be dyspepsia or functional or IBS. And I think to that point, there have been I was initially tickled several years ago to see several different commercials saying, "Oh, do you have bloating? You could have EPI." And I was like, "Oh, well, that's interesting." And sure enough, right? I said, "This is an interesting strategy." Sure enough, now the patients who were told that they have IBS or some functional discomfort, who aren't happy with that very non-specific diagnosis, are now calling their doctor, saying, "I think I have EPI. Can you please check an elastase?" And sure enough, those tests aren't great. And unfortunately, it's kept a lot of us very busy. So education is important, but the nuances and the complexity of it is, so I'm not sure whether, I I think overall it was a good thing because it overall raised awareness, but there's been a lot of focus on trying to educate then patients that, yes, you have bloating, yes, you have these symptoms, but it's not EPI, it's probably something else.
Yeah, it's so non-specific. Sometimes I feel like I have EPI, but in any case, next question, please.
Thank you. This is Syed from Mayo. Questions for Walter. So about this clinical conundrum of a patient who wants a diagnosis of EPI and you want to do a 72-hour fecal fat reduction, who can't tolerate a 100-gram fat diet. What do you do in that circumstance? That's one question. The second one is the last abstract that you pointed to. Now I find that a paradox that GIs are using the fecal elastase more than non-GIs as a diagnostic tool to diagnose EPI and inadvertently prescribing more PUT. What are your thoughts on that? I would rather assume that they'd use a 48 or a 72-hour fecal fat collection instead of a fecal elastase. What do you think?
Yeah, I mean, I think those are great questions. I think, let me just clarify, when you say can't tolerate 100 gram, what do you mean by can't tolerate?
Well, they wouldn't take fat because they would have diarrhea after that.
Sure.
Or steatohepatitis.
Which you would say, well, that's what you want to elicit, right? You want to
Sure,
actually...
But patients are not ready to go on a 100-gram fecal fat or a 100-gram
Yeah.
fat diet.
But-
I'm sure you get.
Yeah, so I think you speak to the general issue of the challenges of a 72-hour fecal fat test, whether it be the toleration of the fat, whether it be the idea of having a bucket in your garage and collecting it for 3 days, right? It's, it really takes the committed patient and the prescriber to really go after that. And yes, historically, it's technically the gold standard for maldigestion and malabsorption. Again, even if it's positive, it doesn't necessarily diagnose EPI. It just says that you're not absorbing fat, and there could be other reasons for that. But, and the appeal for fecal elastase is just its simplicity, despite its limitations in diagnostic sensitivity and specificity. And again, I use it often because it's the test that patients will comply with most. And even then, half the time, they don't necessarily do it. It's... And as an aside, there's a breath test that's available in Europe that may have more potential, and hopefully we'll see that FDA approved at some point in the future. That might provide an alternative way to get at this. But I think at the end of the day, what you see is a lot of empiricism and clinical assessment and empiric trials of pancreatic enzymes as a way to get around it in terms of dealing with this kind of syndromic component. Now, having said that, I think there are patients who probably get some type of partial benefit from pancreatic enzymes, even if they technically do not have EPI either. They actually may have some IBD or some IBS, and they may get some partial improvement with their GI symptoms. Is that a bad thing? I'm not sure, but I think that's partly how we're kind of getting at it.
Considering they cost about $1,000.
That's a big problem. I mean, obviously, the cost of these enzymes, it's probably, and in light of the recent, what's happening in our healthcare environment and the practices by insurance companies to really just, reflexively prior auth everything and implement step therapy protocols for everything, it's a real issue, and it's a big complaint with our patients as well.
Thanks.
Question for Dr. Park. Now, all current available pancreatic enzyme replacements are bovine-based. Do you disclose that to patients with certain religious background, and how do you manage those?
Yeah, great question. I do. I do mention that it's all bovine-based. It often comes up when they ask about whether they can take their elastase measurement as well as being on pancreatic enzymes and listening that the elastase is a human enzyme as opposed to what we give. I don't really have a good solution for the non. I have not found an alternative. But oddly enough, it hasn't been that big of an issue in the last decade of my practice yet, knock on wood. But it has come up a few times, and in those situations, we really didn't have much of a solution other than keeping to, I think what often gets taught is the nutritional component, right? I'm a particular proponent of low-fat diets, and I think often if we can get patients to comply to a low-fat, high-protein diet, they often a lot of their symptoms can be minimized. And I think that's one way to get around. Now, you still have to screen for the fat soluble vitamin deficiencies and other things, but that can potentially manage some of their symptoms to a certain extent. Now, often with chronic pancreatitis patients who are so malnourished, you don't want to encourage them to go on low-fat diets necessarily. And so some of my colleagues will say, no, we should keep them on a medium, moderate to high-fat diet if they're on enzymes. I'm not so sure. I think so long as they get 2,000 to 2,500 calories a day, then that would suffice. So that's probably how I've gotten around it, partially just through dietary modification.
Can I add something? I actually went in Fresno to the imam and the local rabbi, and I asked him the same question, and he said, as long as it's a medicine, it's totally fine.
Please, Dr. Rutman.
Mine was more of a comment. I want to thank Dr. Imam for bringing attention to the epidemic of alcoholic liver disease. I think in my practice, we are being buried under the tsunami of acute severe alcoholic hepatitis. And despite the fact that the pandemic, the COVID pandemic, seems to be somewhat under control, this pandemic is nowhere close to ending. So I just want to bring up this as everybody's awareness, and I think we as a society are going to need to deal with this for years to come. So we need to proactively come up with ways to treat this disease. So thank you.
I definitely agree. I mean, our inpatient service is just full of, young, Willie can speak, acute ALCUP, not a transplant candidate. I mean, it's sad to see, and it's not slowing down for sure.
Yeah, it's an interesting question. Kidist, building on what Marina said, certainly the pandemic sort of drove this increase in alcohol use, but I think many of us think that this is not going to immediately return back to baseline very soon. How as a field, how do we, whether it's patient, policy, healthcare, resources, how do we adapt quickly and sort of address and sort of provide more resources to address the huge burden of alcoholic liver disease that is facing us now, and it's going to be continuing to be a major problem in the field?
I think, I think the driving force is being kind of isolated, and depression being alone, etc., seems to correlate like the timeline, the surge that they had, at least at the script. And I guess reaching out, and if we have any like alarming future from a patient, having them talk about the problem, provide counseling and resources like referral to rehab programs, and also encouraging people to just get on their lives too, like because we're moving out of the pandemic, they should be proactive and going back to work, getting engaged, etc. Certainly, after being vaccinated, hopefully. I think it's just reaching out and identifying the clues and referring them to resources and encouraging people to get back to their usual self-life, I think would be nice. Just one thing to comment, last week, I lost one of my very good patients, who had problems with alcohol, and I think psychosocially she was just isolated. And we've learned that she actually was found dead in her house with like over 200 bottles of wine. So I think I've done a bit more in encouraging her to seek counseling. I think she was seeing a counselor and she was engaged, but it was just too much. I guess just being proactive in reaching out and identifying for the clues would be great. But any insight from others will definitely help us.
Yeah, it's so
as
important
well.
for us just to kind of be more cognizant
Yeah.
of screening and identifying those. Please, Eric.
I have a question for Dr. Cogdill about the abstract looking at gastric emptying studies in patients with dyspepsia and delayed gastric emptying. What is now the role of gastric emptying study in your sort of practice in these dyspeptic patients? Is it sort of initial part of the workup, or is this finding just sort of a artifact of limitations of the study, or patients following the protocol and getting the study until that there was a false positive or false negative?
Yeah, I don't know if I would look at them as necessarily false positives and false negatives. I think that the patients with functional dyspepsia, just like with most functional disorders, probably have some underlying motility issues as well. We're seeing that, IBS constipation probably has at least some underlying, maybe not clearly slow transit constipation, but some underlying motility issues. So I think basically what I think the study sort of highlighted is that patients with functional dyspepsia likely have some underlying motility disorder, even if initially they have a normal gastric emptying study. And maybe, using some of the strategies you use in your gastroparesis patients may also be helpful in your functional dyspeptic patients. So recommending those low-fat diets, the small frequent meals, maybe even more of a liquid-based supplements and things like that. So that's more of the takeaway I had from that, rather than thinking that the gastric emptying study was just a false positive or false negative in those patients. And I think that also, potentially, it's less so, I think, the gastroparesis patients normalizing, I think, is an issue, is more that the functional dyspepsia patients sort of developing more overt motility issues that you might see down the road. And so, I think you could I still use gastric emptying studies, and I think definitely in patients who have functional dyspepsia, I think it is helpful to still do that, but also to consider using the same strategies that you might do for your gastroparesis patients in your functional dyspeptic patients.
Does this abstract make you want to position prokinetics and promotility agents earlier on in the functional dyspepsia algorithm?
So I really try not to use prokinetic agents. So, obviously medications like metoclopramide have such significant side effects, tardive dyskinesia. I've definitely seen that in my practice in patients who are started on that. So unfortunately, we just don't have great motility agents, prokinetic agents, I think, at this point. So I primarily tried to do more of a diet-based approach to the patients. I hope, though, maybe in the future, I think that could be something hopefully, if we can see safe agents that we could use in that regard, that this may be sort of an overlap where we might be able to use them even in our patients who have normal gastric emptying study but have functional dyspepsia. Thank you.
One question that I think this came up in one of the abstracts you presented, Asha, is sort of the role of probiotics, prebiotics, how do we use it, what are the data? So I'm curious, from your perspective in, functional dyspepsia or IBS, and also from Sarah's perspective in IBD, how do you approach pre and probiotics, or do they even use those kinds of agents?
Yeah, I think we had an amazing lecture yesterday on that, and I actually learned a lot from that. I really enjoyed that lecture. I think that the most recent ACG guidelines looking at IBS, I think that came out this past year, really didn't recommend the use of probiotics. There just isn't enough data there. And so it's something that, and some patients have even reported harm or worsening symptoms with probiotics. So I think basically that study sort of highlighted that there may be some role for them, but we still know so little that we don't know which probiotic to recommend. There haven't been head-to-head trials. They're not FDA regulated. So I think there is going to be a role for them in the future, but we just don't have that information now. Prebiotics, I think similarly, we just don't have enough data to really recommend them routinely in all patients. So it's something that, I think there's a lot of promise there, and I think that's what that study was highlighting, is that potentially probiotics, and particularly maybe some targeted probiotics, may be able to alter the gut microbiota, may be able to actually improve dyspeptic symptoms, but we still need more data on that.
And it's a similar situation in IBD as well. I think my fellows are tired of hearing the same spiel over and over again that I give about, about the microbiome, and this is really the tip of the iceberg, and we don't have elegant ways of manipulating the gut microbiome just yet. So we have these very coarse tools that we can use, such as probiotics, but it's hard to match the right probiotic to the right patient to have there be a match that's there. Really, in IBD world, thinking about pouchitis and the Visbiome now is the brand, proprietary brand, that there is some data to show for that, but otherwise we kind of give caution with trials of probiotics.
Great, thank you. Please.
Thank you all for great talks. Dr. Lewin, can you remind us, in the piano registry with corticosteroids, was budesonide included in the group that had negative adverse first trimester outcomes, or are we primarily talking about systemic corticosteroids?
So the main analysis was done with corticosteroids. The budesonide data, I think there was not a high enough usage of budesonide alone to do an adequate subgroup analysis. So really, I think the take home is really that when patients are having significant flares requiring systemic corticosteroids, that's really what we should be trying to avoid.
So in terms of your practice, you have a flaring first trimester IBD patient. Are you gravitating towards budesonide first if you need a corticosteroid, or is it really just the message is do what you have to do to control the flare, since that is still the most significant problem?
Exactly. I think the goal is to control the flare with steroid sparing means necessary. I think it depends on what therapy they're on already. If this is a patient in their first trimester that's on mesalamine only for their ulcerative colitis, I think in addition to starting budesonide at that point in time, that you would be trying to get them onto biologics quickly as well to try to escalate their therapy. But I think that probably more importantly, it would be to get the inflammation under control as soon as possible. So you can do a trial depending on the severity of their flare, probably would be what would dictate that. But preferring budesonide over systemic corticosteroids would be the way to go if it's sort of more of a moderate type of flare.
Thanks. I'll put in a quick plug that there's another great abstract looking at men and pregnancy and IBD, and it was very reassuring that fathers who were on any kind of biologic or immune modulator, including methotrexate and thiopurines, there was no increased risk in adverse childhood outcomes, including congenital malformations. So that was one of my favorite abstracts. Not to.
There were too many. There were too many. I had to. It was a tour de force.
Good news
Yes.
for fathers and good news for
Yes.
mothers. So thank you very much.
Thanks, Ryan.
Thank you. I have a question for Kidist, and this is, to preface it, a tough question. I think we sort of talked about this a little bit yesterday. So the last abstract you presented, I think, is very fascinating. And time and time again, we highlight these disparities, particularly for Black, African-American liver disease patients, that they don't get good screening, poor rates of early diagnosis, poor access to treatment, poor survival. It's interesting that, this group at UT Southwestern has done so much in trying to address these disparities that they found when you correct for institution, that at least some of these disparities sort of are mitigated or perhaps even disappear. But we also know that the vast majority of cirrhotics are not, at least first line, not cared at academic centers. So I'm curious your thoughts on how we can try to use what we learn from these kinds of studies and expand it to sort of non-traditional academic centers to kind of help, mitigate some of the disparities that we currently face.
I think, it's just a multifactorial problem. I don't think it's just that piece of access to care. I think, socioeconomic status and education of the patient is important. And I think providers, we all have a big responsibility of avoiding, learning about cultural diversities and avoiding referral bias is really important from our end, and just empowering our patients with different types of educations, etc., so that they can be involved in their care. I think, it's just multiple factors, and I think they all are intertwined, and we have to figure out an algorithm that could really help patients navigate the system and get care. But I think it's important to note that when they finally got to the medical place they need to, like an academic, probably tertiary quaternary center, their outcomes were the same. So I think it's everything behind that is the problem. I don't think there is an easy answer. We just all have to work together to help them in a different level.
Perfect, thank you.
I mean, you've done a lot of work in this, and
Yeah, it's so challenging, as you said. I think there's no one size fits all and no perfect answer to this, and it's not going to change overnight too. And so I think you bring up some really important points that, from a health system standpoint and perhaps even policy standpoint, first we have to be more aware of it, and then try to think of innovative ways to address it.
I think, there are many studies that are saying here are minorities. You can start with heart disease, liver disease, anything, cancer, right? Our outcome or their outcome is not the same as everybody else. And hence, I don't see any particular like robust study actually showing implementation of changes making a difference. I think you've done some work in that regard. One of the papers you presented at our American Liver Foundation conference last time on diversity showed like you guys did pre and post intervention and there was a huge difference. I think research and figuring out what really is the cause and then implementing or coming up with a program and moving that forward instead of just beating the drum about the problem is really the next step, and that starts from all of us.
Yeah, and that's, true across diseases too, not just
Yeah.
hepatology. Please.
So it's a quick comment on what you just both commented on. Probably because academic centers are in urban cities that the poor people have easier access to. So in Berkeley, where our poor patients have difficult access to hepatology and GI because of insurance issues, we have hepatologists who come from academic centers to Oakland, like Will Holt here, and that has made access to academic centers easier. So maybe the academic centers have to come to patients
Definitely.
by putting these, once a month will come, which made our life easier. Just a suggestion.
Thank you so much for that comment. So we're coming up on time. So one final question to end it. This is for Dr. Park. For patients with chronic pain from chronic pancreatitis, you talked a little bit about neuromodulators. Do you use that in your practice and sort of how you incorporate that?
I do. There's only been one study to my knowledge that actually looked at it in some type of trial, and that was Lyrica, pregabalin, but I often will start with gabapentin as a consequence because of its generic and cost.
Perfect. Thanks. So thanks everyone for joining us for this morning. So now we're going to go on. We have a 30-minute break. So please come out to visit our booths, our sponsors. The poster session will also be out there in the room there. Also remember, Eric mentioned this earlier, but there is a raffle. So make sure to pick up your raffle, get all your bingo stamps, because I think there's a prize. There's a $100 prize. And you have to submit that before the end of the break to the registration table. So be sure to submit your raffle. So far there was nobody. So if you were that one person, you automatically win. So definitely make sure to check that out. And then be sure to come back to join us. We will reconvene at 10:40 a.m.